what I'm going to do is spell out the rest of the week's topics, because between what I already have and what I want to do, I think we have a full week, and we can add any new ideas the next week. I think what we'll call today is testing, either 102 or part 2, depending on how you want to phrase it, because I can go on for days about testing. Another issue I want to get on board with is COVID patients seem to have a weird, different oxygen requirement. And they're not behaving the same in the ER and on the floors and in the ICU as your typical patient who's getting hypoxic. So I think we really need to learn from the clinicians in New York and Italy. This is really important for our internists and our ICU docs to realize that in a lot of these patients, you can be hypoxic down to an O2 sat of 80 and be sitting there just talking to you just fine. Those people probably don't need to be intubated and on a ventilator. But I can tell you the reflex of any doctor running a code, you guys call code blue on a person sat at 80%, you're shooting Versed and paralytics and tubing them right now, because that's just what we're trained to do. That may be doing more harm than good, and it's taking away a ventilator for somebody that needs it. Because I think they're supporting people with hypoxia uniquely in this disease, and I think we need to understand that and come up with protocols for our hospital so we don't waste ventilators on people that are doing okay. And I can't emphasize how important that is. And this is precedent in New York and Italy already, so we don't need to reinvent the wheel. And I say that every day. Let's not do the same things everybody around the world. That's the advantage of being in Cass County, Missouri. Is we're not in New York right now. We're not in Paris, and we're not in Italy. We haven't been hit at this point yet. So let's learn from them and be ready for it. So I want to cover that this week. Immunizations, just because it's one of my favorite things to talk about. And I can talk for days and bore you to death about immunizations. And I probably will. But I don't think I can put all these together and have you guys stay awake. Final thing I want to cover, and I shared this with Liz last week or the week before. There's a great video on masks that does way better than I could ever do, showing you the science. That's some beautiful imagery and some fantastic stuff that will really have it sink in what the value of these things are, both in this room, but when you go to the grocery store, when you go to the park and everything. And I think it's going to be a normal way of life. Like I suspect when we all go to the Royals games in the fall and Chiefs games next year, we're going to have Chiefs and Royals masks that are handed to us instead of the little whatever the thing is that day. The Royals are going to have 40,000 KC Royals logo masks they're handing out. And that's just how we're going to watch baseball from now. It's just going to be a new normal. You can choose not to wear it. That's fine. There's nobody that's going to violate your First Amendment rights. But, it's just a new normal. Kind of like after 9/11, we learned to manage airports with a new normal. So, Liz, I'm going to ask you to, since you're kind of taking on the administrative charge of this meeting, can you work with Justin on maybe we can hook up the video to show the mask video either tomorrow or Thursday?
Is it on an internet site?
Yeah.
Then we can do that. I'll look at it. I should know how to do that.
Frankly, it'd be good if we could do it for tomorrow. It's a great video, and then we can put the link on the internet.
People all I have to do is one of us has to log in, and
I figured it's super easy.
We could quick try it after this one.
Okay, great. Because I'd like to sit here while the video is playing and point out things I think are important. But it's really a cool video. And it's been formative in my urge to get everybody to wear masks as much as possible. Okay, so with that said, Liz, you have this. This is our agenda for the rest of the week. And I'm going to focus on testing 102 today. I'm super excited to hear, and I literally did a happy dance. Liz sent out an email last night about, is that public knowledge? Testing sites?
Yeah.
So as far as Harrisonville Family Medicine is going to become a drive-through testing, is that the way I understand it? As soon as today?
Well, he said they were hoping today. I don't know if it got off the ground, but
yeah.
I haven't had an email yet.
I can't tell you how important that is to Cass County. Because up until this point, we have not had a reliable place to safely send patients who are symptomatic but didn't need to be in an emergency room. And unless you are able to test those patients, it keeps us safe, them safe, and we have no idea where this virus is. Because if you're relying on people coming into the emergency room, for every one person coming in the emergency room, there's probably 10 to 100 people that they've infected or who have silent infection or others that are waiting to get sick based on that one person in the ER. And if we can't do high volume throughput testing, we're never going to be able to get control of this. Again, every single time I come in here, I draw the same graph. Where are we on this graph, guys? We are here.
yeah, just
On the linear phase. We have not yet reached our first doubling time. In fact, Cass County, as far as I know, only has 3 deaths today. Another person died in the nursing home today, I think. So we have 3 deaths, and until we reach 5, we're not even on the clock. That means
5 a day?
no. 5 total deaths is when the clock starts, and when you get to 10, that's your first doubling rate. Every 10 up to there is just, you have no idea how rapidly it's spreading in Cass County until we actually get to 10 deaths. We can't, the testing means nothing. And just quit paying attention to reports of how many people test positive. Because it's completely unreliable data. Not because the testing's wrong, but because we're not testing everybody. And so we have no idea what the denominator is. The testing varies from Kansas City to Harrisonville to St. Louis to New York to Paris. It's just not universal. So the only thing that you can compare place to place is the number of deaths. And until you reach 5 deaths, you can't estimate where you are on the curve. So until we're at 3, which means we're actually still here, which is great. But I can't emphasize enough how important it is to us to do more while we're still linear before we're exponential. Because once it's exponential, it's like trying to put out a fire with gasoline being poured on it. It's going to be really hard. But at least we can contain this if we all do more. I haven't felt this level of passion in days because I've suppressed it. But I can't tell you how important it is to know where we are on this curve. And the only way, the best tool we have to contain this virus is testing. It's not Plaquenil. It's not ventilators. It's not all these other things. Social distancing is one of these tools. And we've been implementing that back here. Okay? But testing has to be our highest public health priority by far. Because with testing, more testing, you can do contact tracing. And you can find out other people that are positive at early stages. And you can prevent them from going to the grocery store. And you can prevent them from coming to work. And you can prevent them from visiting their grandmother. Because you know that they were exposed. And the only way you can do that is have high throughput, high quality testing, which is just starting today here. But it's great because it's on the linear part of the curve. Okay, so I've given you guys lectures on the difference between a nasal swab test and the antibody tests. Okay? What I want to talk about today is theoretically different type of tests and where they fit in on what we should be accomplishing. And then talk about surrogate tests, because somebody asked a question. They heard that maybe chest x-rays or CT scans should suffice for testing. And that's actually very true, and I want to explain why. Okay? Just today, if you guys want to read a summary article that is written for you guys, everybody to understand, the Annals of Internal Medicine just released this today. It is their review article, April 13th, so yesterday. called Diagnostic Testing for Severe Acute Respiratory Syndrome-Related Coronavirus 2, a narrative review. And it will, in pretty simple terms, explain the difference between PCR, serologic, some tests we haven't even heard about that are coming online, and then x-rays and CT scans. And also the public health responsibility of all of these. And I'll cut to the chase. This says we need to do more testing now in mass amounts. And it all comes back to here, because once we're here and our limit, again, surge capacity of the healthcare system is there. We can't act quick enough to make changes there. We'll save one life per day here. We can save tens to hundreds to thousands here. And it's so hard to understand that concept because you can't see the car wreck yet. But you can start to see the brake lights piling up in front of you. Okay? So let me recapitulate an image here. I'm sorry for not writing this out earlier, but in the disease we have incubation stage. We have symptomatic illness, and then we have convalescence, right? I love the word convalescence because it reminds me of 1950s, and before when they had convalescent homes, and you just thought about people who would go there to sit in the sun and recover. So these are on a continuum of time. And the ideal thing for epidemiologists to do is to do some screening of our population of everybody and know our exposure. Because we know data on this that we're probably asymptomatic even though we have the infection for 5 to 7 days before we feel sick. And if we have a test that can detect those people, then we can isolate them before they spread it to anybody else. And that's exactly what South Korea has done. Okay? And you do this with highly specific tests on everyone. My proposal is that we have a test that we could run on. I mean, the only environment we have 100% control on is this hospital, right? And I would propose we test all of us today. Now, we don't have the resources to do that, but that's the best thing we could do to make this the safest place in Cass County to work. Because we're going to find, some people that are asymptomatic carriers, or we may find people who have already have antibodies and are protected and have already recovered. We'll find that if we screen enough people. But that's an ideal test. And that could be, a PCR-based test, or it could be an antibody-based test. It's just an epidemiological widescreen test. What we're doing in real life is we're starting to screen people early in their symptomatic phase. And probably the best test for this is a nasopharyngeal swab PCR test. Now, some things we didn't talk about this. The whole impetus of the news articles this past weekend were based on that I've discovered there's other people in this world who already knew it. I came to a realization. There's a false negative rate of the process, not the test, the process of about 30%. And that's because, one, we don't have the right kind of testing swabs. You have to have a bristle brush thing with a metal rod, and you can't use cotton and all sorts of other things that we're doing makeshift things. And you need to run it straight to the PCR machine. I'm not going to recapitulate that. We could theoretically, according to this, we can start doing our throat swabs also if we don't have nasopharyngeal swabs, because that's the second best source between nasopharyngeal swabs. And I can tell you, it's a lot less uncomfortable doing that swab than it is this swab. The false negative rate increases a little bit, but if you don't have a nurse or a clinician who's willing to put that swab all the way to the depth it needs to be, then you might as well be doing a throat swab anyway. And we have a heck of a lot more equipment to do throat swabs, right? I don't know, it's called a strep test, right? So it's the same thing. Anyway, we should be doing that up front. A test here that's not going to be effective is the antibody test, because, as I mentioned, it takes several days after you've seen the virus probably a week to 2 weeks before you actually start making antibodies and they're detectable. Plus, we don't have, currently there are no companies in Kansas City or Cass County that I know of that are offering the antibody test. But they will soon, because as I'm going to get to in the convalescent phase, it's really important we do those so that we can safely go back to work for our own personal safety. You want to know if you're making antibodies. So you don't get, as we talked about yesterday, can you get reinfected? Absolutely. If you don't have a good immune response. And you don't want to go back to the front lines after having been sick for 2 weeks if you haven't protected yourself. Okay. So this is probably not an ideal place to do that. What happens here is we start making treatment decisions. Okay? And those can occur anywhere on this subcontinuum. I mean, the best thing is you have a drive-through clinic that has, you have fevers, cough, chills, diarrhea, anything basically. If you present with a viral syndrome, in today's day and age, it's coronavirus, maybe flu, maybe strep, coronavirus, right? It's kind of like a silly differential diagnosis with 7 out of 10 being COVID-19. So we want to test the patients there when they're early on, and the first treatment should be to send them home and self-isolate, quarantine. And contact tracing for everybody they've been in contact, all the people that live with them, and everywhere they've been in the community in the last few days. And that's how you control this virus. Okay? What if that comes back negative? 3 days later, if they're still symptomatic, guess what? You do it again. 3 days later, if they're still symptomatic, you do it again. Serial testing is the key to negative tests. If you test them 12 times over 2 weeks and they're all negative and they recover, I feel confident they probably did not have COVID-19. And that's what every expert in the world is saying right now. So we need more resources. Right here, we need people willing to volunteer to do drive-through clinics from our standpoint, from healthcare standpoint. We need more swabs. We need personal protective equipment. We need media to put these in there. And we need a PCR machine to send them to. Okay? But you should go home. Nobody needs to be in the hospital unless you're hypoxic. And it goes back to one of my very first lecture I did on my YouTube channel, March 19th or something. Still applies today if you're watching. Stay home until you're hypoxic or short of breath. Don't go anywhere in this world that involves another human being unless you have to when you're sick. If you get sick and it's symptomatic, you can go downhill quick, get a mask on, go to the ER. Okay? And then they'll test you again, but they'll start treatment. And this goes back to, again, early in the phase, I still believe that there may be a role for hydroxychloroquine. Our hospital has it readily available. If you get admitted to this hospital with hypoxia, and either you've tested positive or you have a clinical index of suspicion that you have this, you need hydroxychloroquine today, according to me, if I'm your doctor. And you're going to get it for at least 3 days until your test comes back either positive or negative. In which case you're going to get another test if it's negative and do this whole thing again. Hydroxychloroquine is too safe to not have some faith in it. Okay? All right. Here's the new part of today. Sorry if this is redundant. What about other tests? Chest x-rays and CT scans are great surrogate tests. Okay? So obviously you can't go to Walmart and buy your own x-ray machine. And we don't have drive-through CT scanners. So when do these apply? They apply in the emergency room and in the hospitals. And I'm going to show you the data on this because I think it's very, very fascinating. And this was referenced in the Kansas City Star article, by the way, based on good science. So if you're symptomatic and we don't have time for the state lab to have a 72-hour turnaround on your test, and you're already in the emergency room because your presenting symptoms are hypoxia or shortness of breath, we need to know whether you're sick with coronavirus to protect us against you and you against everybody else. chest X-ray and CT absolutely have a role here. Absolutely. And the role is pretty simple. Chest X-ray I'm not real sold on, but I'll give you the data on, and you can make your own decision. CT scans are great. Radiographic testing. So the chest X-ray will detect anywhere from 11% to 100% of patients, depending on when it's done in their illness. And that range is really not good. So if you test mildly symptomatic patients early in their symptoms with chest X-rays, you're probably only going to detect 10% of people who truly have the coronavirus at that point. Not a great test. It's not very sensitive. A sensitive test will detect 100%. That's what we're looking for. If you test people in the ICU on a ventilator, well, guess what? 100% of them are going to look like they have bad stuff going on in their lungs by chest X-ray. It's cheap, quick, easy. It goes down to they can do a portable chest X-ray in the ER. They might as well, but they're doing it anyway, right? Because the ER, you basically go in the ER with a hangnail and you probably get a chest X-ray. Because it's a $15 test and low radiation exposure. The more interesting one is CT scans. And I'm not saying don't do this. This is like taking your family photo from outer space. There are satellites that can get an image of you and your family smiling on Christmas, but it's not the best quality. But if you get, a CT scan, you got a professional photographer in your living room, and it's going to look great. And that's exactly what a CT does. If you scan a mildly symptomatic patient with shortness of breath or cough, and then later on you find out they have coronavirus, the diagnostic accuracy is 78% to 100%, again, depending on where they are in infection. So what this is telling you is that the false negative rate of CT scan is 22%. Right? Did I do the math right? 22%? What did I tell you the false negative rate is up here? It's like 27%. This is a better test. Not for screening mildly symptomatic patients, but for people in the ER. And frankly, if you wait till here to do a CT or do a nasopharyngeal swab and you wait for the state lab to turn it back, even if it's 24 hours, you lost 24 hours of time that you could have been giving this person Plaquenil. Right? And that's really important because you got to start Plaquenil before the virus has gone replicated so much that Plaquenil's not going to help you. Time is everything here. This is a test we can turn around in the ER within minutes. And it has a better false negative rate than the best test we have in the world. So, if you're symptomatic with a cough, hypoxia, and need to go to the ER, you should get this test. And you should get this test. And that should be standard protocol in every ER around the world, I think. Because I can't tell you what a rapid throughput this is. Okay? All you have to do is clean this with Lysol after you're done and you're ready for the next patient. And then we feel with a high degree of confidence we can treat these people, isolate them, put them in the right part of the hospital away from the other patients that are coming here with broken legs and heart failure and heart attacks that also need to be here. Really, 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 really important. To the point that, I think our hospital needs to make some decisions about what we know. And again, we're remiss if we don't. Because, where are we on the curve? Linear. Let's make some protocols here, make some change. I'm highly enthusiastic today. Because we're still linear, and I have a lot of hope that we can make some changes based off this science. This isn't just guessing. This is science from New York, science from Europe, science from China. It's real. The final thing I'll say is ancillary testing. You've heard about doing things like you can check albumin levels and CRP and LDH and lymphopenia, low white count, SED rates and ASTs and ALTs. They all play a role in this. Their sensitivity and specificity is all over the place, It's just like pneumonia, the flu, all these tests with viral infections are always all over the place. They have no role in diagnosis, but they're probably going to be ordered by the internist and the ER doctors because that's what we do. But they're not going to help us diagnose things. This thing, and antibody testing here, so we can go back to work safely, are game changers. We have this today, finally. We have this, had it all along. Haven't needed it yet because we haven't been overwhelmed. And then we're getting this really, really, really soon. So let's set up protocols to make this easy on the frontline people so they know what to do without having to think. All right? Is that a passionate enough lecture for today? I feel good about it. All right. We're done for the day. Hopefully you guys learned something. But I encourage you to read this article. It's an easy read.